We know that the vast majority of thyroid nodules are benign, and we know that despite our increased detection of these cancers, we have not improved on the survival of thyroid cancers, and a very large number of them were detected accidentally or incidentally on these scans.
Some people are very anxious about this, and sometimes that's our fault for not explaining it. The vast majority of thyroid nodules are benign. Thyroid cancer is a very slow-growing malignancy. It is an indolent cancer, and that it has a very, very high cure rate. We do not necessarily need to remove these thyroids, that we can treat them before they become symptomatic and a huge problem, that we can improve on that without a scar, without thyroid pills, and through a relatively safe, quick outpatient procedure.
Welcome to Save Your Thyroid, a podcast all about thyroid nodules. My name is Jennifer Holcomb, and I advocate for fellow patients suffering with this very common condition. Thyroid nodules impact 70% of adults in their lifetime, and the standard of care is surgical removal of half or all of the gland. But in recent years, safe and effective non-surgical treatment options have become available. In this podcast, I sit down with patients and physicians to discuss life with thyroid nodules, treatment options, and how to save the thyroid whenever possible. Today's guest is Dr. Antoine Eskander, a head and neck oncologist and reconstructive surgeon at Sunnybrook Health Sciences Center, head and neck disease site lead at Odette Cancer Center, and chief of Otolaryngology, head and neck surgery at Michael Garron Hospital in Toronto, Canada. Dr. Eskander is an internationally recognized researcher in several areas, including head and neck cancers, health services research, clinical epidemiology, and quality improvement. His research interests include topics such as access to care, disparities in care, adherence to guidelines, volume outcome associations, and quality metrics. In today's discussion, we explore the balance between patient empowerment and the anxiety caused by incidental nodule discoveries, the importance of individualized care and shared decision-making, the significance of better outcomes at high-volume treatment centers, and the value in choosing the right physician. We also discuss thyroid RFA and the benefits of de-escalating treatment of thyroid nodules and cancers when appropriate. Dr. Eskander, welcome to the podcast.
Thank you so much for having me.
It's really wonderful to meet you. Actually, just recently interviewed another physician from Toronto, Dr. Jesse Pasternak, and I am excited to meet you today because the Canadian population and the Save Your Thyroid community is growing, and the patients that want to learn RFA in Canada is growing, and they're very excited anytime they learn about physicians who are doing these non-surgical treatment options for thyroid nodules and cancer. So today I want to start with you just kind of introducing yourself to the community. Tell us about your background and how you came to be doing RFAs in Canada.
Yeah, so my name is Antoine Eskander. I go by Tony. I'm a endocrine and thyroid surgeon at the University of Toronto, specifically at Sunnybrook Health Sciences Center and at Michael Garron Hospital. I'm an associate professor. I'm also a health services researcher that studies our healthcare system and how we can improve the delivery of healthcare, not just at my hospital, but at a provincial and national and sometimes at an international level. And thyroid cancer treatment and thyroid nodule treatment and parathyroid disease treatment is a very large an important part of my practice, and it's one of my favorite things to treat, and they're some of my favorite patients to take care of. My pathway to treating thyroid disease was medical school at the University of Toronto, followed by residency at the University of Toronto in otolaryngology and head and neck surgery. I then did a fellowship in advanced head and neck cancer treatment, and that was done at The Ohio State University in Columbus, Ohio. During my training, I also did a Master's of Science degree at the Harvard School of Public Health. And since then, I've gone on to also do additional training in quality improvement. And I've studied thyroid cancer and parathyroid disease extensively, specifically in Ontario, Canada, at a provincial level. It's funny, I use the word save your thyroid in my clinic visits with my patients. I try to tell patients my job is to try to save your thyroid and to try to not remove your thyroid if it is not absolutely indicated or absolutely necessary. And
I
so
love that.
it's funny because I heard about your organization and your movement by by looking it up and actually just searching those words, save your thyroid.
Oh,
Like, how
wow.
can we save people's thyroid? And many of my own patients over the years where I've been kind of reluctant to offer them surgery for something that I think most surgeons would offer them surgery were large benign thyroid nodules that were slowly growing. And a few of them came to me after my reluctance to operate, and they had radiofrequency ablation done in the United States. And I already knew about the treatment and was frustrated that we could not yet offer it in Canada. And so we offered it as quickly as it became Health Canada approved. We've had some excellent results, and our patients are extremely happy with it. But like many other things, radiofrequency ablation is going to take time to really settle into the Canadian landscape. And so right now we're doing a lot of education to other surgeons and endocrinologists and trying to get the word out that you can save your thyroid because that's currently not really the most common way to treat this problem in our jurisdiction.
Definitely. And it's still not really the most common way here in the US, even though we've had the access available since late 2018. And of course, the pandemic slowed down growth of that, but there's still a very huge lack of awareness, unfortunately. So one thing that is kind of important to me is that we can maybe help inform physicians through our patients as they go to their primary care physicians and their local ENT or endocrinologist and inquire about these procedures that are saving to the thyroid, localized treatment, to shrink thyroid nodules, in some cases thyroid cancers, that, maybe that the physician will hopefully hear this from the patient and then take it upon themselves to go research it. So I am so interested to talk with you today about your experience with research, because you mentioned your experience with studying the patterns and causes and effects of what's going on in the healthcare system and how you can improve the actual definition of clinical epidemiology. And I will read that just for the benefit of the viewers, because, the viewers of this podcast are primarily lay people like myself. And so I want to read this really quickly. The study of patterns, causes, and effects of health and disease in patient populations and relationships between exposures or treatments and health outcomes. And I just think that is such an interesting concept to consider, the differences between outcomes when you are comparing a population of patients treated with surgery versus treated with non-surgical treatments. What are your thoughts on all of that? And do you have any experience with research that you've done that we can maybe even discuss?
So first of all, we know that the incidence of thyroid cancer continues to rise and has been rising for many decades. We know that the incidence of thyroid nodules, I'm going to say incidence, but in brackets here, in quotation marks, the incidence of thyroid nodules has also been rising. And that's because we are really good at detecting them through all sorts of tests, MRIs, ultrasounds, CT scans, done for a variety of reasons, headache, carotid disease, other things. Our technology has gotten better, and so we've picked up many thyroid nodules. What's interesting is that we know that the vast majority of thyroid nodules are benign, and we know that despite our increased detection of these cancers, we have not improved on the survival of thyroid cancer. So it's not like if you pick up more of them and you treat them earlier, somehow you are going to cure them at a higher rate. So we are likely over-treating thyroid nodules. We are likely over-treating thyroid cancers. And we have done a number of things in Canada to try to curtail this over-detection through the Choosing Wisely campaign, which is a campaign that is led by physicians for physicians. We have put out some recommendations that suggest that neck ultrasounds should not be performed when patients complain of indistinct neck discomfort or pressure or a feeling of something stuck in their throat. That is very frequently not related to thyroid nodules at all, and a physical exam is all that is required in that scenario. And so we've tried to curtail this over-diagnosis through the Choosing Wisely campaign, and our society, the Society of Otolaryngology, had a neck surgery put out those recommendations that physicians should not be ordering ultrasounds in those scenarios, because that is, and we actually studied it in a study using both Canadian and US data, a very large study led by the American Head and Neck Society, which is how are thyroid nodules detected. And what we did is we looked at the first 100 patients in each physician's practice that had thyroid surgery. And we looked back and said, how were they detected? And a very large number of them were detected accidentally or incidentally on these scans. And so we know that's a major pathway for that. And so when you put it all together, we're over detecting, we're not improving outcomes. Physicians are part of the cause for this, and patients should be very careful about when they get their thyroid or neck imaged and what the implications of that are. Most of the time, you do not need to have your thyroid removed, but sometimes, of course, you do need to have additional interventions, whether that be a biopsy or a surgery or one leading to the other. I don't know if that directly answers your question, but it gives you, it's my version of what is happening with clinical epidemiology in the thyroid world right now. And that's my answer to that.
Well, and I think you brought up some really good points there about overdetection leading to overtreatment. It's kind of a two-edged sword when you think about it, because it's empowering to know what's going on with your health. I mean, I'm an advocate for patients to ask for the testing that they feel like they need, but at the same time, having these incidental discoveries, these incidentalomas, as we sometimes call them, come up on, say you've had a car accident and you undergo testing for that, and then you learn you have thyroid nodules, it's kind of terrifying. We have over 10,000 patients in our community, and so many of them come to us after this incidental finding. And I think that as I was kind of preparing for this interview, I was thinking about how it's good to have standards and basically kind of a formulaic approach to how you address diagnosis of a patient. But at the same time, we're also very individual. And so I get sort of trapped between those two ends of a spectrum. We've got the end of the spectrum where we're overdiagnosing and then overtreating as a result. And then on the other end, we have this very individualized perspective of treating every patient differently because we're all different. And how do you really kind of find a balance between those two where you're not, trying to put everyone into a little box and treat everyone the same, but at the same time, not needlessly worrying the patient? I don't know if that was like a very overly complicated question, but I think that's what's so interesting to me about what you're seeing in your research. How can we kind of combine these two things and balance them out?
Yeah, that's a really great question. It's probably one of the most enjoyable and also challenging parts of my job, our job, is that, we talk about patient-centered care. We talk about shared decision-making. We talk about not being paternalistic and not insisting that a patient do something. At the end of the day, I can say as a physician, you can't force a patient to do anything. You need to inform them about the risks, the pros and cons. And quite frankly, even the way you deliver that message might be different if you're talking, for instance, to a 14-year-old adolescent who's going through a thyroid cancer diagnosis versus an 85-year-old gentleman or an 85-year-old woman who's in a wheelchair and on oxygen and was accidentally discovered to have a thyroid nodule that is likely not malignant. Those two conversations, even though there's the same initial starting looking nodule, might have very different undertones, and you really need to put the whole patient together. Quite frankly, including their anxiety a little bit, because some people are very anxious about this, and sometimes that's our fault for not explaining it. And I have a few key things that I tell patients. I almost tell them, I say, I want you to remember, if you're going to forget a lot of things I said today, I really want you to remember this. And some of those key statements I tell them is that the vast majority of thyroid nodules are benign. And then in the patient where I'm a little more concerned, or we've worked down the pathway, and maybe they do have a malignancy or they have a potential suspicion for malignancy, I say that, I'm sorry that we're having to talk about this, and I'm sorry this may be distressing to you. I want you to know that thyroid cancer is a very slow-growing malignancy. It is an indolent cancer, and that it has a very, very high cure rate. And sometimes I'll even quote them, if I have the information based on their risk, I'll quote them their chance of cure, which for the vast majority of patients is upwards of 95%. And I think by them hearing those facts and us spending the time to explain it and getting feedback and then repeating it and spending the time to have the conversation, patients can be well informed and can make the right treatment choices. That is not to say that every thyroid can be saved. Of course not. Some thyroids do need to be removed for a variety of reasons, and it's usually those patients that are requesting it after they hear the pros and cons. But in the case of RFA, the historic thing was, I have a 4 centimeter thyroid nodule. It's benign, it's growing. Well, you don't really have a choice. You need to have it removed. Well, I don't want to have it removed. I'm young and it's not really bothering me yet. Well, you need to have it removed because we can't be sure that it's not malignant. Well, what's the chance of malignancy? Isn't it quite low? I have a biopsy that shows it's benign. In fact, I have several biopsies that shows it's benign. Well, you can never be sure because it's such a large nodule that how could we be sure? I need to remove this because it's malignant. I think the days of that, hopefully, are slowly ending as we get the word out.
Yes.
That that's not the case, that we do not necessarily need to remove these thyroids, that we can treat them before they become symptomatic and a huge problem. And that certainly in those that are cosmetically not acceptable or symptomatic, that we can improve on that without a scar, without thyroid pills, and through a relatively safe, quick outpatient procedure with some minor sedation. This is the shared decision making that needs to happen. And it will be different for every patient. And I think that's the art of medicine. That's the part of it that requires a little bit of extra thought, attention, that's individualized and holistic.
So several comments I have to make on what you just said. First of all, when you commented on taking the time to just inform the patient about the statistics on benign thyroid nodules, that is probably the main thing that I get so upset about when I hear a patient come to our community who is terrified that they're going to die. They've just learned that they have this incidentaloma. They just found out they have a thyroid nodule. They don't know anything about it, and their doctor didn't take the time to educate them on it, and they're scared they're going to die. That happens so frequently. And so I love that you start off right off the bat saying you educate them on that statistic. So important because they're so common. And then about the treatability of thyroid cancer, that it is usually a very indolent disease. So important and, so exciting when we think about that some of these papillary thyroid cancers can be treated with RFA. You mentioned in our correspondence prior to this interview about your research on volume related to outcomes for patients and that you were inducted into the Triological Society for that data. So I would love to hear more about that.
Yeah, we talk about, if you just want to carry on from what we were talking about, we talk about patients being informed, patients telling their physicians about some new treatments. For instance, not all physicians know about radiofrequency ablation. And so because you're advocating for patients directly, and I really love what you're doing, another thing that patients can advocate for themselves on is by learning the facts around which surgeons should and should not be necessarily doing their procedure, whether that be RFA or whether that be a surgery. And this is a really old story. This is not a new story, but I feel like patients are not very well informed about it, which is that it's actually kind of common sense, is that providers and hospitals that do more of a particular procedure have better results. And this is ubiquitous. This is true for anything. Whether you're getting, a lung problem treated, or whether you're getting a thyroid problem treated, or whether you're getting a breast nodule treated, it is true that when you go to a provider that provides more cases per year, that they tend to have better results. And we're not just talking about short-term results like, complication rates and length of stay in the hospital and the chance of injuring the nerve to the voice box or the parathyroid glands. We're talking actually about hard oncologic outcomes, like cancer outcomes, like your survival, your ability to be cured is actually improved. And this has always been an interest of mine, but this is not a new story. But I would say I'm the person who's kind of studied this the most in Canada and has bridged the gap between the Canada and the US in this. What we found in that particular study that was done in Canada was that there's a huge range of surgeons doing these. The lowest quartile, or the lowest group of surgeons, was doing between 0 to 17 cases per year. So to put that in context, that's one case of thyroidectomy, whether it be partial or complete or whatever, every 4 weeks. That's not a lot of cases. The highest volume surgeons were doing somewhere between 100 to 300 cases a year. And then we studied all of them together. And we found something very interesting, which is that after about 40 cases a year, the results are flat. So if a surgeon is doing more than 40 thyroidectomy cases a year, whether it be for benign disease or cancer or for any cause, that they tend to have better cancer outcomes when they treat a cancer patient. So their cure rates are higher than for surgeons who did less than 40 a year. And maybe that's not surprising. And I have many theories as to why that might be. I will tell you that as a thyroid surgeon, I find that when I'm doing a lot of surgeries, even in a given month, that I'm more efficient, my surgery is more complete, and there's a lot of nuance. There's a lot of little structures and little details that can happen during the surgery, and you're more attuned to those things. It's like a musician who can kind of hear those notes or hear the orchestra that's just a little off. You can pick up and fine tune things in a way that you can't when you're only doing the surgery once every 4 weeks. So I believe it. The other thing is that surgeons that do a lot of this surgery are protected by usually a tumor board and an organization and a structure around them that reviews difficult cases to make decisions about who should get additional treatment or completion thyroidectomy or radiofrequency ablation. And there's additional protection in those surgeons that do higher cases. This is not to say that all of these thyroid surgeries need to be done at, for instance, academic centers by surgeons that are professors. That's actually not the truth at all. That's wrong. Many of these surgeries can and should be done by community providers, whether they be general surgeons or otolaryngology head and neck surgeons, so long as they also do a lot of thyroid surgery. And I can tell you that in Ontario, Canada, my jurisdiction, there are many incredible thyroid surgeons who do 100, 150 cases a year who are community otolaryngologists, and they do such a marvelous job. So none of this data was meant to hurt them or to say that they shouldn't be doing it. In fact, they're the ones that should be doing it. You need someone who does a lot of it. But it also depends on the type of thyroid operation. Not every thyroid operation is the same. Some, for instance, are very large and go below the breastbone. And again, not every thyroid surgeon does those cases or does them in significant volume or does them with the right support. Similarly, some patients with thyroid cancer or thyroid disease also need their lymph nodes in the lateral neck removed. Again, that's not an operation everyone does or that everyone does in very high volume. And so for those, or some people have the thyroid cancers invading their windpipe and they need to have part of their trachea removed. Again, requires some additional expertise. So I went on and actually did another study. So the 40 number is for any thyroid cancer patient. If you're a thyroid cancer patient and you should lean towards being treated by a surgeon who does more than 40 cases a year. They tend to have better results. And before I talk about those other rarer cases, what led me to even look into this question is that many of my own patients would ask me, they would say, first of all, are you doing the surgery? I say, of course I'm doing the surgery. Like, who else is going to do it? You're here to see me. I'm getting you to sign the forms. They say, okay, and how many do you do a year? And some surgeons get really offended by that question. Like you're kind of questioning me, or you're imposing that, or you're suggesting that maybe I'm not good at doing this. But I actually think it's a very thoughtful question by the patient. And I would encourage patients to ask that question.
Agreed.
And if a surgeon fumbles or is uncertain or doesn't want to answer or is offended, you might want to question why that is. I think it's nice for them to say, I certainly do more than 50 cases a year, or I do more than 20 cases a year. Or I do more than 100 cases a year, or something, but they should know their general numbers, that they do about one a week. And if they do more than one a week approximately, or more than 40 cases a year, that's very protective and that they're likely a high volume provider and can be trusted. And so those are very important questions by patients. And just to finish my trail of thought, because there's another associated study, in those patients who have thyroid cancer, and it has spread to the lymph nodes on the side of the neck. Again, not a situation where we can save their thyroid. They do need thyroid surgery. We found that procedure, that lateral neck dissection, is a unique group of thyroid cancer patients. And that in those patients, it doesn't matter how many thyroid operations the surgeon has done. It matters how many lateral neck dissections the surgeon has done. And so you want to find a surgeon ideally who does a lot of thyroid surgery, but also who does more than 20 cases a year where they need to remove the lymph nodes on the side of the neck. And that could be for any reason. not just for thyroid cancers. That could be they're removing it for other cancers or even benign disease, but that this was protective. And so some thyroid surgeons don't do this operation at all, or they do it once a year because it's relatively rare for thyroid cancer to spread to lateral neck lymph nodes, relatively rare. And so there's some nuance as to how patients at a healthcare system level can kind of shift themselves towards providers that are providing kind of higher quality care as it relates to thyroid cancer. So patients should not be scared to ask that question, and providers or surgeons, physicians should not be offended in terms of answering that question either.
I love that. I think that is so important. And as you mentioned, not every thyroid can be saved. That's totally true. And we at Save Your Thyroid are not advocates for surgery being evil. I mean, surgery is necessary in some cases. And we do counsel patients that if you are going to have surgery, if you need to have surgery, just as you were saying, you need to find a physician who has a high volume to be able to not ensure, you can't ensure an outcome, but to hopefully predict the best possible outcome. And I think that's so interesting that you were able to actually look at data that showed what these different outcomes came from as far as the physician's experience. So aside from asking the physician about the number of surgeries they do in a year, are there any other practical tips for patients as far as finding a high volume surgeon, any kind of resources that we could refer to as patients?
Yeah, that's a great question. For RFA, that does exist. There's a very strong network for RFA, and that's really easy to kind of find online through StarMed and through other websites that essentially link them to providers in their region. There's like a map and you can click and see. And that's probably because that's a rarer treatment, isn't it? And so it's easier to lay everyone out on a map. But for thyroid, there's just so many surgeons who provide thyroid surgery and who are good at providing thyroid surgery. I can't speak for all surgeons and all specialties, but I can tell you within otolaryngology head and neck surgery, the American Head and Neck Society, AHNS info, that particular website, has a really robust endocrine section and has great information about their surgeons on that section. In fact, you can look up surgeons and their experience and expertise. The website does not provide you with their case numbers per year for a variety of reasons. One, it would be kind of hard to put on the website and it changes per year, and what if it's not accurate and all those things. But they are protected in that they are appropriately trained to do that surgery and are typically a quite high volume in doing so. So that's one such website. But truthfully, there is, because a lot of people are trained to do thyroidectomy very well out of residency. I can tell you that during my residency training, just my training, I was exposed to over 400 thyroids during those years of training. And then you build from that and you become independent and you grow. So I don't think there's really a good centralized resource, US patients for Canadian patients, to identify who are going to be those high volume surgeons. And just because someone works at an academic center does not necessarily mean they are high volume per se. I mean, it's likely they are, but it would still be a fair question to those surgeons as well, who devote themselves or dedicate themselves to treating this disease.
I would like to ask this question too regarding the differences in our healthcare systems. In Canada, I believe it's more based upon referrals. And then in the US, we have a little bit more, I guess, ability to choose. And so when it comes to choosing a physician with a high volume, what would you suggest to patients? Is there a way for them to be able to have an element of choice in this situation, or are they going to need to stick with more of that pattern of referral?
Yeah, no, I mean, patients can see any surgeon they want in Canada by doing their research and by asking for a referral to be sent. Some patients will ask for a second or a third opinion, and those are provided. It's included in our system. It's not a huge deal. I will say that there is a little bit of misinformation in that somebody who has a university appointment or is affiliated with the university or is a professor is somehow certainly higher volume or does better work than somebody who works at a community hospital who also does this in high volume. And in fact, I've trained many individuals who have gone on to work in that community setting. And so when I see a patient who's being sent to me as a second opinion, From a high volume community surgeon, I say, you don't need to have your surgery done by me. It actually doesn't make sense. You should go ahead and have your surgery done by the surgeon. And I encourage them to ask those questions that I asked, like how many cases do you do a year? And I tell them in general, if a surgeon does, 40, 50 to 100 cases a year, that's pretty high volume. And that surgeon can be trusted to do your surgery. So every hospital, or almost every hospital, has a surgeon who is like their thyroid surgeon or is their high volume surgeon. And so if you live in a smaller community, and not so small that it's rare or there's no thyroid surgery happening, but even if you live in a smaller center, you go to a smaller center, not necessarily an academic center, and you're not seeing a professor of surgery, you may still have a surgeon in that region. And there is value to local care. There's less cost, there's less travel distance. Of course, if you have a complication, it's easier to manage when you're closer to home than you're flying in and out from somewhere or driving a long distance. So there's value to local care. But what I would advocate for at a health system level is that each local community have a thyroid expert, and that thyroid expert be high volume instead of it being kind of disseminated or distributed and then nobody is high volume. And so, yeah, even in the differences in our healthcare system is I think there's a little bit more traveling, I think, in the US across state lines. I will say that in Canada, that's relatively uncommon, even though it's covered, but it's just relatively uncommon because it's unnecessary, because there are high volume providers in each of those regions. And that even within a province, there's some traveling happening. Some of it's appropriate and some of it's inappropriate. And sometimes it's hard for patients to know. And part of the impetus is on us as providers to kind of educate them and say, no, like really, it's okay. You just need to ask these questions to understand if it's appropriate.
Yes, you're exactly right about the traveling aspect. We do see, particularly with RFA, because it isn't available everywhere, it's only available in certain areas. And so patients will travel to areas where it is available. We see a lot of traveling just in specialties. My hometown in particular, most people who live in this area will actually drive about an hour and a half to 2 hours away from here to see endocrinologists, because there are very few endocrinologists in this area. And usually if you want to see one of them, you're going to wait 6 months to a year to get in to see them. So they go to the university one state above us. And so that's why I'm hopeful, kind of pivoting over to the topic of RFA, as this procedure continues to grow in prevalence and availability, that there will be less traveling needed. For me in particular, my physician who did my RFA, I'm located in Alabama and he's located in Texas. And that's like 1,000 miles away for me to go see him for follow-ups. It's been 5 years for me. So, I'm no longer in that beginning stage where the follow-up is so important to be done on, short periods of time. But, I would like to go see him for my 5-year ultrasound, and I can't do that right now. I'm hopeful that the more we see physicians taking on the procedure and we see it growing, we will see less travel, and those local physicians will have the ability to get more high volume just through having more patients. The list that we maintain on our website, saveyourthyroid.org, we have a list of physicians there who are doing all of these procedures that we are aware of now, the thermal ablation, non-surgical procedures. That list is just growing and growing and growing. So that's very exciting to us, because 5 years ago, we literally knew of just a very, very small number. And also, it's very exciting to us about how many are now available up in Canada, because it's not been that long, maybe just a year or so now, that it's been available in Canada. Is that correct?
Yeah, that's correct. Yeah, it's been since April of 2023 that we got Health Canada approval, and then we got it soon after that. But we were waiting for quite a while. Like we were ready and waiting, and it was just a matter of getting that final approval.
Well, let's talk about your experience in RFA. Tell us a little bit about your practice, how you're doing this in your practice and how it's going.
Yeah, it's going really well. Even prior to April of 2023, every one of the rooms I see my patients in has its own ultrasound. I do all of my own biopsies. including some of the more complex biopsies, not just for thyroid, but core biopsies, which are really large biopsies that remove tissue, like a significant portion of tissue from neck masses. And so I felt very kind of comfortable learning about and initiating a radiofrequency ablation program. I typically do these cases with my partner, so the patients have the benefit of having two physicians in the room with a nurse in the room. We do these in our clinic, which is in the hospital. You don't need to do these in the hospital, but it's kind of nice to have that protection of being in a hospital. We do it in a monitored setting, so the patient is monitored. There's usually some light music in the background chosen by the patient. And for me, the most important step, other than obviously picking the right nodule and the right patient with the right reasons and all of that stuff, for me, the most important step is getting the numbing medicine in and getting the fluid in around the thyroid. And I find if I do a really good job at those steps and I talk the patient through it, that the rest of the procedure almost always goes very, 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 very smoothly. We also give them a small sedation medicine. Some patients honestly tell me, I don't want to take it, prefer not to. And I'm like, that's fine. That's, not a problem. You don't have to take it. It's just to take the edge off if you wish. And some patients are so anxious that I give them 30 minutes before the procedure. And right before we start the procedure, they're still feeling really on edge. And I say, why don't we just do one more? And I give them one more and we wait another 10 minutes and then we start the procedure. Usually they're laying flat for the procedure and we're talking the whole time to them, like we're communicating even during the procedure. And there's a lot of checks and balances to make sure it's going well. Usually they're in and out of the office within a kind of a 2 to 3 hour period. And usually we can get 3 to 5 cases done in any given day. It's been a huge benefit to our patients. I've seen some very happy patients that have come in with very large visible thyroid nodules that they've been carrying around for a long time, and they've not wanted their surgery because they don't want to give up the lump for a scar.
Right.
And they don't like the concept of maybe I might have to take thyroid hormones, which I completely understand. So they've been waiting. And then after you do the procedure, even very early on, they say like, my neck's just smoothed out. You can measure the size, but I don't care. You've already achieved the goal, which is I don't notice it as much. Some patients who are bothered by it, like they said, it bothers me. It's in my throat and it pushes. Initially, that doesn't go away because there's still swelling and there's still growth, and the process is still happening of the nodule shrinking. So in fact, sometimes they complain of worse symptoms initially, but eventually when you talk to them, they say, oh, this is much better. Now that it's shrunk, I feel that sensation's gotten much better. Let's say I was a 5 out of 10. Now I'm at like a 2 out of 10 in terms of how much it's bothering me. And just the sheer volume reduction in those patients who aren't bothered by it at all, but we know it's growing. I've been following them for years and it was 3 centimeters and then it was 4 and then it was 5 and now it's going up to 6. And then you treat it and it shrinks down with a significant volume reduction. That also makes me really happy because those patients, when they're young, they are going to end up potentially needing surgery at a later stage when the nodule and the thyroid is so massive that it's causing symptoms. So this provides you with an opportunity to really shrink it down and prevent that need, especially for a young patient,
Right.
50s, 60s, because often those surgeries for the really big benign thyroid masses are when patients are in their 80s, and that's a process that takes decades, and you can stunt it and prevent it from getting there. So it's really been a game changer, particularly in Canada where our wait lists for surgery are so long. This has really given patients an avenue to get, in my opinion, a great alternative treatment that is equal, if not better, than surgery in many cases.
Wow, that's so exciting. Especially love when surgeons adopt RFA. Unfortunately, we see so many patients who are just like, all surgeons want to do is do surgery and remove my thyroid. I love to be able to show them that's not true. That's, when a surgeon has tools in their toolbox, which may include surgery, may include observation, and now RFA and other non-surgical techniques. That's so exciting to show patients that we're working together. We're not on opposite sides here. I'd like to take a moment to thank the sponsor of today's episode, QualiSure Diagnostics, the developer of Thyroid Guide PX. Not all thyroid cancers need to be treated with extensive surgery. Thyroid Guide PX is a test that can determine if cancer is slow-growing or aggressive. Knowing that you have a slow-growing cancer may help you and your doctor to determine if observation, less extensive surgery, or thermal ablation might be right for you. If you would like to learn more about this test, please email admin@qualissuredx.com or visit their website, qualissuredx.com. A heartfelt thank you goes out to QualiSure Diagnostics for sponsoring this episode and supporting this channel. Now, back to the podcast. You mentioned core biopsies. Can you talk more about that? Because that's something we've actually had a few patients ask about. I've witnessed a few in certain clinics that I've been to where I was actually filming procedures. And I think it's a very interesting option to be able to kind of give more insight about what's inside of this nodule. So can you talk more about that for a moment?
Yeah, for sure. The first thing I'll say is that core biopsies are rarely done for the thyroid. It is by no means the standard of care. Fine needle aspiration biopsy is well studied. It's lower risk procedure because it's a finer needle, and it is quite accurate at detecting benign from malignant for the most part, and it's easy to repeat. Core biopsy is a bit more of a procedure, particularly in the thyroid, which is a very vascular gland, where you're actually inserting a needle under ultrasound guidance usually, and it's a thicker needle. It is significantly thicker, and it has a sheath over it.
Mm-hmm.
And that needle goes in with the sheath and eventually creates a space or a core that will be removed, again, under ultrasound guidance. And then the sheath, it's like a gun, it snaps and you hear a snap, and that snap is the sheath going over the core area, and it actually removes a portion of tissue, the length of that needle, into the sample. When do I use this for thyroid? I use it for thyroid when I think it's a really bad tumor, like an anaplastic thyroid cancer, which are extremely rare and very fast growing. And it can be used for benign thyroid, and it is actually in the RFA pathway. To get to RFA, you could get a core biopsy that's benign to qualify for RFA, although I have to say I've never had to use that to get a patient to qualify. What I typically use it for more frequently is for people who have lymph nodes that are concerning for lymphoma or other cancers. It's a non-invasive way of sampling that lymph node without making a cut on the skin when the fine needle aspiration, the small needle approach, was non-diagnostic or not useful.
And that was my next question, is if you have a patient who's had multiple non-diagnostic biopsies, would that be a potential next step?
That is certainly an option. Often those non-diagnostic biopsies are related to the fact that there's cysts or fluid in the thyroid nodule, or related to the technique or the area that was sampled. And so I would make sure I would click off everything else on the list of what could have been done better to prevent a non-diagnostic. But of course, if it's a solid mass and every needle that's been done has been non-diagnostic, then a core biopsy is not unreasonable and would provide additional information. But very uncommon, very uncommon.
Thanks so much for watching this episode. I hope you're enjoying it. You know, this podcast requires a lot of my time, effort, and resources, but it is a labor of love. If you'd like to directly support my work here, you can do so in two different ways. You can purchase products from one of my affiliate brands, or if you would prefer to make a donation directly to the podcast, you can do that as well. Links to do either are located in the description below. Every dollar contributed goes right back into this podcast. Additionally, if you'd like to support the Save Your Thyroid patient advocacy community, which is working toward becoming a nonprofit organization, you can donate via our fiscal sponsor, THYCA, Thyroid Cancer Survivors Association. Simply visit thyca.org, click donate, and designate your gift for SYT. To learn more about us and the work we do, please visit saveyourthyroid.org. If you have any questions about any of this, don't hesitate to email me at saveyourthyroid@gmail.com. Any way you choose to support the podcast or the SYT community is sincerely appreciated. Your generous contribution keeps this work going and helps us to help more patients like me and you. Thank you so much for watching, and now back to the podcast. Any other thoughts you'd like to share pertaining to maybe de-escalation of treatment? Because I feel like all of your research that you've done on outcomes, looking for the best possible outcome, really comes down to trying to de-escalate treatment, to try not to overtreat. And so do you have any other thoughts you want to share on de-escalation of treatment regarding thyroid nodules and thyroid cancer?
Yeah, I mean, I think the best thing we have towards de-escalation is one of the things we talked about a lot, which is this volume outcome association, and seeing a provider that understands the increasing incidence, the increasing problem, the increasing complications associated with overtreatment of thyroid disease. And they can de-escalate for you, or they can help you with the de-escalation plan, truthfully, because they are more likely to be knowledgeable about RFA and ablative technologies. Alcohol ablation is the other one that we quite like for purely cystic thyroid nodules. And they're more likely to do a partial thyroidectomy than a total thyroidectomy, or know the appropriateness of that. So again, all of it has to do with seeing the right person to help us de-escalate. At a health system level, that's a far more complicated question. What can we do as a health system? There's many complicated interventions we can do. In some health jurisdictions, you can't order a thyroid ultrasound unless you are a particular type of physician. It's almost like special access, because they realize that if they tightened up who could order it, then you're less likely to get these incidental findings. That's a really hard thing to push for in North America. I think that's unlikely to succeed. But there are many other approaches, like going directly to patients and informing them, further educating physicians about over-treatment and over-imaging these things. But I think what we can actually do best is just have the right people treat the right patients. I think that is a form of de-escalation, because they're more likely to be aware of alternatives and all of those things.
I think education is a key point here too. It sounds like on both sides, the patient side and the physician side, that education is so critical. And so I appreciate so much everything that you've taught me today, because that's truly what happens when I do these interviews. I learned so much, and my goal is to pass that along to the patients and hopefully distill it down to put it in layman's terms. And I really appreciate your time today, Dr. Eskander. And I guess maybe the last thing I would just like to ask you is, tell me, I haven't done this in a while, but I used to do this pretty frequently. Tell me your elevator pitch for saving the thyroid.
It's important to try to save your thyroid, because even though we have medications that can replace the hormones that are produced by it, some patients just don't feel the exact same after being on those medications. We don't fully understand why, but it's a real phenomenon, even though their blood tests are normal. This happens in a minority of patients, but for that reason and that reason alone, we have to be very thoughtful about in whom we should remove thyroids, because otherwise it's a very safe procedure when done by the appropriate person. But because of that thyroid medication implication, if possible, and if it's not completely necessary, I would try our best to preserve the thyroid.
Thanks so much for listening. Please share this content and help others. If you need resources, testimonials, and support, please join our patient community, Save Your Thyroid. You can also find me on social media and Substack under the media handle, It's Me, Jenna Gunn. Never forget to educate yourself and be your own advocate and save your thyroid.